Learn about the work facility infection. We'll start with ventilator associated pneumonia. Ventilator associated pneumonia is an infection which occurs within one set of 40 to 72 hours of hospitalization, development of new or progressive infiltrates in chest X-ray, fever, leukocytosis, and purulent tracheobronchial secretions. This infection was neither present nor incubating at the time of hospitalization. So, variety of factors are responsible for ventilator pneumonia. One is the host factors, then surgery, then medications, then invasive devices, and respiratory equipment. All the four factors, in fact, actually leads to oropharyngeal colonizations and gastric colonization. The effect of this oropharyngeal and gastric colonization is aspiration of the organisms, and depending upon the number of the bacteria and the virulence, the lung defenses are compromised, both cellular or humoral or mechanical, and because of the organism's translocation from other sites and bacteremia, they further aggravated, leading to pneumonia. What are risk factors? Patient risk factors are age, burns, coma, lung disease, immunosuppression, nutrition, and burn trauma. While device related factors are invasive ventilation, duration of invasive ventilation, reintubation, medication, prior antibiotic treatment, and sedation. What are the general precautions for prevention and control of ventilation pneumonia? One is the staff hygiene, the staff education, then hand hygiene, then isolation precautions. Then we have surveillance of infection and resistance with timely feedback and adequate staffing levels. General precautions, if you see the specific about intubation and ventilation, avoid intubation and reintubation, prefer non-invasive ventilation, prefer orotracheal intubation and orogastric tubes. Continuous subaortic aspiration is a class 1 recommendation, and cuff pressure should be more than 20 centimeter of water, and avoid entering of contaminant condensate into the tube or a nebulizer. Use sedation and weaning protocols to reduce the duration. Use daily interruption of sedation and avoid paralytic agents. So among this, the category 1 recommendations were avoid intubation, prefer non-invasive ventilations, and continuous subaortic aspiration. Now regarding positive end expiratory pressure. Positive end expiratory pressure. Now a technique is used in respiratory therapy in which airway pressure greater than atmospheric pressure is achieved at the end of exhalation by the introduction of a mechanical impedance to exhalation. The range should be about 0 to 15 cm water. For surveillance, 0 to 5 cm water is equivalent. That is positive end expiratory pressure. A sustained increase in the daily minimum of this PEP of more than 2 cm of water following a period of stability or improvement is a sign of deterioration. For example, calculate daily minimum PEP. Fraction of the inspired oxygen. The fraction of the oxygen is in inspired gas. It can be adjusted depending on the patient's oxygen needs. The range is 30 to 100%. The sustained increase in the daily minimum fraction inspired of oxygen of more than 0.2 or 20% following a period of stability or improvement of the ventilator is the second of the two criteria that can be used in meeting with the ventilator acidity events definitions. For example, calculate daily minimum fractional inspiratory capacity. After a baseline period of stability or improvement on a ventilator defined by more than 2 calendar days, stable or decrease in daily minimum fractional inspiratory oxygen or PEP value indicates ventilator condition or ventilator pneumonia. If you see the VSE, it is an increase in the daily minimum baseline of fractional inspiratory capacity of oxygen of more than 0.2. It's sustained for more than 2 calendar days. An increase in the daily minimum baseline PEP more than 3 units sustained for more than 2 calendar days is considered the VAC. If you consider the IVAC, it is temperature of more than 30 degrees or WBC high or more than 12,000 or less than less than 4,000. Then a newer antimicrobial agent is started and controlled for more than 2 days constitutes the IVAC. VAP, that is ventilation pneumonia, positive cultures, purulent secretions, histopathology, evidence of pneumonia constituted VAP. Systemic and antibiotic selective decontamination of the digestive tract reduces the incidence of VAP to contain MDR outbreaks. That is category 1 recommendation, selective decontamination of digestive tract. But HDT is not recommended for routine use. They are again category 2. Prior systemic antibiotics help to reduce VAP in selected patient groups, but it increases MDR. 24-hour antibiotic prophylaxis helps in one study but was not too useful for. So stress bleeding, transfusion and hyperglycemia tend towards lesser VAP with sacral plate versus H2 blockers, but increased gastric bleeding is an issue with sacralfate. Prudent transfusion, leukocyte depleted RBCs transfusions should be considered. Intensive insulin therapy to keep the glucose should be considered. Aspiration or body position. Now, semi-recombinant position at 30 to 45 degrees, especially when receiving enteral feeding, is recommended. Enteral nutrition is preferred over parenteral because of the translocation. There is an interesting article on the multifaceted program to prevent VAP. It is the impact on compliance with preventive measures. It mentions stresses on adherence to hand hygiene, adherence to glove and gown use, backrest elevation maintenance, correct tracheal cuff maintenance, orogastric tube use, gastric overdistance avoidance, and good oral hygiene and elimination of non-essential tracheal. That can be effectively prevented by hand hygiene before and after patient contact, avoid the intratracheal intubations, use of oral rather than nasal tubes, minimize the duration, promote the tracheostomy when ventilation is needed for longer term, and gown and gloves used for ET2 management. Now, what not to do is avoid non-essential tracheal suction, oral hygiene with chlorhexidine, backrest elevation 30 to 45, and maintain tracheal compression more than 20, avoid gastric overdistension, promote enteral fitting, careful blood sugar control, and SDT. Again, to summarize, at least 30 to 50% of all healthcare associated infections are associated with five basic patient care practices: use and care of catheters, use and care of vascular lines, therapy and support of pulmonary functions, experience with surgical procedures, and hand hygiene precautions. Thank you.